Welcome to Lesson Learned, the official podcast of the Curriculum Instruction and Assessment Department at Midwestern Intermediate Unit 4. I'm your host, Shannon Smith, and today we're diving into early intervention for early psychosis, why timing matters. Today's episode pulls back the curtain on an often misunderstood challenge in education. How do we recognize and respond to students with emerging psychosis? It's about breaking the silence, moving past stigma, and building systems of support that go deeper than discipline and stronger than one-time trainings. Our panel today includes voices from across the field, including Dr. Melissa Nelson, our K-12 school safety and security expert, Dr. Monica Calkins, psychologist and psychology researcher, and Dr. Alex Moxham, a child and adolescent psychiatrist. A multidisciplinary group of people who are looking at this together so that multiple angles of understanding and support are represented. Today we'll ask the hard questions. What are the early warning signs we're missing? How can schools move from reacting in crisis to building cultures of connection, prevention, and care with a community of providers? I thank you for joining me in this studio today. If you please introduce yourselves to our guests.
Hi, Shannon. This is such a pleasure to be back with you today after a few other podcasts that we have recorded. I am especially excited to be joined by two exemplar colleagues in the field of early psychosis who I've gotten to know over the past year, who will do nothing but provide us with incredible information today to help us in schools to approach K through 12 approaches to early psychosis.
Hi, Shannon and audience. I am Monica Calkins. I'm a licensed clinical psychologist and professor of psychology and psychiatry at the University of Pennsylvania. I've been working in the area of schizophrenia and psychosis for more than 30 years, and that includes both research and clinical work for young people and their families who've been experiencing early psychosis symptoms. Much of my work is focused on biobehavioral risk indicators of psychosis, but also related to that is how we best identify and intervene when a young person is starting to develop psychosis. So that includes also outreach into the community to help raise awareness and education about early signs and symptoms of psychosis that might help us get people to care earlier. And it's a pleasure to be here today.
Hello, I'm Alex Mox. I'm a child and adolescent psychiatrist, also faculty at the University of Pennsylvania with a clinical appointment at the Children's Hospital of Philadelphia. So far, my career has been focused on clinical interventions for early psychosis. I started and co-direct Children's Hospital of Philadelphia's first episode psychosis program, and we've been up and running for almost 4 years now. And I've gotten to work with Dr. Calkins, Melissa Nelson, over this past year. Dr. Calkins a little longer, as she is a mentor of mine, and a real pleasure to be here today.
Thank you, everyone. So for those of you listening, whether you're a teacher, an administrator, a parent, or just someone who cares about young people, this conversation is for you. First, I was hoping that we could maybe identify some of the stigmas or stereotypes that are associated with early psychosis, and even looking at perhaps some of the terminology or mental health literacy that we need to be mindful of before we even begin today.
So unfortunately, schizophrenia and psychosis is not the same as schizophrenia. Psychosis is sort of a set of symptoms that could represent schizophrenia, but doesn't necessarily. It is the most highly stigmatized mental health disorder. And Shannon, as you've said, that there's a lot of misconceptions out there. Much of it's perpetrated by the media, where we get constant exposure to messaging about what psychosis is when things that it's not. So one of the biggest stereotypes is that psychosis is always associated with violence. And we know that in fact, for serious mental illness, that the rate of violence against other people is about 2%, and that's the same rate as what the rate is in the general population. So it really is not much higher. Also, there's the misperception about mass shootings being caused by people with psychosis or schizophrenia, when we know that the vast majority of mass shootings do not involve anyone with a history of serious mental illness. So those are some of that's one of the biggest to get out of the way right away, because those images are so pervasive. in our culture, and actually cultures all over the world. Some of the other stereotypes involve sort of the idea that if somebody has schizophrenia or psychosis, that they're not going to be able to work or have a job. And we know those things are false. In fact, especially with early intervention, people can return to work or school and go to school with, especially for younger people, return to a school setting that's a standard school setting and be with their peers. And in fact, that's very helpful and important for the recovery process for a young person, so they can achieve their education, or for older adults, their employment goals. There's also the idea that people will not be able to reach and maintain recovery. That's, sort of like that once you have a diagnosis of schizophrenia or psychosis, that, it's kind of hopeless or lost cause. And we know that it also is not true, that people, especially when people do get early intervention, that people can reach and maintain recovery in various kinds of ways, and not necessarily meaning the total absence of symptoms, but, in ways that a person can enjoy a quality of life, can function, can have, a sense of hope and optimism. And that's what we think of as a recovery-oriented approach to thinking about psychosis and schizophrenia. Dr. Moxham, I don't know if you would add anything to that.
I think the only thing that I would add is that psychosis and the diagnosis of schizophrenia are very alarming, and they have lots of stigma, as you mentioned. And I think I do a lot in my work is help normalize and identify psychosis symptoms outside of the diagnosis of schizophrenia, as it can be normative or typical to have transient psychotic-like experiences in moments of high distress or at certain ages, or as while you're falling asleep or waking up, and help contextualize anomalous experiences or psychotic-like experiences in someone's life.
What do we actually mean when we talk about students at risk for psychosis? Is this a process of defining it through behavior, diagnosis, systems data? Is it all of the above?
So often we're looking at symptoms that the person may have. Those include ideas that other people that may be false, or perceptions. We think about people talking about hearing voices or other things that aren't there. There's also what we call negative symptoms, which include kind of a diminishment of the person's typical experiences. So the person may show little interest or pleasure in things, may lose motivation to do things. Sometimes the person may have disorganization, where they're having difficulty expressing themselves, talking in a way that makes sense. In school, that can look like a person having difficulty following lectures or tracking conversations or completing reading assignments. If someone's experiencing those perceptual experiences at school, they may be distracted while trying to concentrate on exams or presentations. If somebody's feeling suspicious of other people, they may withdraw from other people, so because they're afraid of other people. And also there can be cognitive problems like trouble with memory, attention, or planning.
So, what are some of the most common early indicators or warning signs that get overlooked when a student may be exhibiting symptoms of early psychosis?
So prior to psychosis onset, there's usually or often some premorbid disorders such as anxiety or ADHD. So these students may already be on someone's radar in terms of already having an IEP or 504. And then it's helpful to have if possible, to have a longitudinal connection with these people, because you do, as I mentioned, see a change from their baseline in terms of declining cognition, maybe more withdrawn, more suspicious, less engaged in activities they previously were. Another identifiable risk factor often is substance use. So if you're noticing that they're coming to school intoxicated, usually with marijuana, or noticing that is something they're engaging with more, that puts them at increased risk for developing psychosis.
So Dr. Moxham and Dr. Calkins, so that in schools, educators don't start jumping to conclusions or thinking, as Dr. Calkins said, Dr. Moxham said that ADHD might be present and there might be an IEP for that. What are the true percentages around early psychosis? Because we have many students in schools with IEPs for more high incident disabilities like ADHD or anxiety, but truly, or we have many students who we acknowledge either because they tell us their lived experience of substance use, or we look at data like PAYS data and we know that substance use is prominent in some areas with students. How do we, what percentage of students are we really talking about that end up having a diagnosis with early psychosis?
Well, so about 17% of children aged 9 to 12 years old do have sort of psychotic-like experiences, and about 8% of adolescents aged 13 to 18 have psychotic-like experiences. But that doesn't necessarily mean that those symptoms are going to become long-lasting. So as Dr. Moxon was saying, some of those symptoms can be transient, and in fact, they're transient in most children. The thing is that we don't have a crystal ball to know who is at risk for having those symptoms become worsening and more severe over time. The evolution into whether they persist or worsen, is influenced by things like substance use, but also trauma, or more, whether the person has also depression or anxiety, how severe those symptoms are to begin with, socioeconomic disadvantages, being part of a minoritized, traditionally marginalized population, and very importantly, a genetic family history of psychosis. So if a person has first degree relatives, that's a parent or a sibling with a psychotic disorder, that rate is going to, the risk is going to be higher. Overall, the rate of schizophrenia in the general population is 1%. So that's 1 out of every 100 people. And the rate of other psychotic disorders is about 4%. So we are talking about relatively, it's not, I mean, they're common, but they're not as common as, ADHD, but that should hopefully give some sense of what you might expect.
To continue on that line, is there a danger in over-pathologizing students who exhibit intense emotional or behavioral reactions? And where's the line between a struggling student and a truly at-risk one?
So I'll talk a little bit from a school perspective, my concerns about over pathologizing, and start with the framework first of our typical training as educators. The vast majority of us are not qualified to provide a diagnosis. And so when we start thinking about over pathologizing, it is definitely a danger to have a checklist in our hands and not understand context to that checklist. So I'm always concerned when we start learning a little bit more from a literacy standpoint that we don't understand that we need people like Dr. Moxham and Dr. Calkins who can provide more context and deeper understanding of the checklists that we have, because once we start over pathologizing, what we tend to do in schools then is start thinking of every child who exhibits a normal life reaction to something like stress. Like maybe they're worried about preparing for a test and they're worried about it, or they're feeling a little stressed about that. Well, that's a normal life reaction. But if we start calling everything like that anxiety, and we start saying every child has anxiety or symptoms of anxiety, then what happens is we can't tease apart the children who are truly struggling with anxiety. So the same goes for early psychosis. If we start going through checklists and deeming every child then as having not just maybe a symptom or 2 symptoms of early psychosis or whatever Dr. Calkins and Dr. Moxham would tell us needs to show up on the checklist, then we just have a danger of then the children who truly are struggling not being seen anymore. So that's what I would say from a school perspective is it's why we need to be working and collaborating and relying on people like Dr. Moxham and Dr. Calkins to help us understand symptoms that we see at a deeper level.
I think I just want to be upfront too that it's really difficult to identify someone who's what we would call clinically high risk, or someone who is in that state where they're teetering between intense depression, anxiety versus psychosis. But there are, I think, with questionnaires that have been developed and relationships are formed between counselors or school workers and patients, ways to identify people who are generally in distress and have psychosis symptoms as part of that. in order to guide them to appropriate mental health care. I think in terms of over pathologizing, kind of like what I was saying earlier of not jumping to diagnosis use or focusing on psychosis symptoms because they're usually part of a larger context in terms of school avoidance, anxiety, social anxiety, eating disorders. There's almost always in the early phase something else going on as well, that the psychosis symptoms, delusions or hallucinations that are somewhat related to. So the psychosis symptoms can more just be a marker of psychological distress rather than as identifying someone who's developing a psychotic disorder. Because really I think the school is mostly just trying to find those people who are in distress and making sure they're getting the appropriate help.
Yeah, and just to piggyback on that, so we have developed through our work, and we have a screening tool that's available. It's only 5 items. It is age normed, which means that you can see from the screening tool whether or not the young person is endorsing a level of symptoms that is atypical for their age. It still doesn't mean that they have necessarily psychosis or are at risk for psychosis, but it kind of gives you an indicator that this is a potential red flag. And then we have an accompanying algorithm where you can or flow chart that kind of walks you through some steps to take in order to be able to refer that young person on to someone who can do a more formal evaluation of the kind that Dr. Moxon was talking about. So that's just something that will be available in Shannon's podcast newsletter.
Now, from a school perspective, it is not the school's responsibility to diagnose. So in many ways, how can we kind of open up this discussion and make our educators feel more equipped to address any behavioral health issues? How can they responsibly balance observation, concern, and actual referral when it comes to early psychosis?
Yeah. And, this is actually the work that we've been collaborating on, relates to the work that we've been collaborating on, where we're doing a school screening of school professionals, mostly school counselors and school psychologists. And we have preliminary results so far from 196 individuals from across the Commonwealth of Pennsylvania. And one of the interesting things is that less than half of individuals do report having a working understanding of psychosis, although most do correctly recognize 2 key symptoms of psychosis. That's the delusions and hallucinations. And about half report they've worked with students who hear voices or have strongly held beliefs. So definitely these situations are occurring in schools. I think the majority of people actually had low confidence that they would know the risk factors, but more than 80% said they're interested in learning about risk factors. And the majority have low confidence at 75% in their ability to identify psychosis symptoms. But the vast majority indicated that they'd be willing to learn how to screen at-risk students using that tool that I mentioned. So I think that the interest is there, and it's a matter of sort of connecting that interest and the desire for school professionals to be able to do this kind of screening with information and knowledge on how to do it. And we do offer free trainings that are available across the state of Pennsylvania for people who might be interested in schools and districts that might be interested in participating in that.
Yeah. Sorry, I was just going to say, I'd say not having to make a diagnosis is a huge relief, probably. Like just not having to even consider what the diagnosis is really allows, I think, the school workers and clinicians to just be able to appreciate symptoms. And then with these screeners can match symptoms to need for referral.
Shannon, this study that Dr. Moxham and Dr. Calkins and I are collaborating on is such a great example of educators saying, look, when we're asked, we know we don't know this, or maybe we know a little bit about this, but we really want to know, because at the end of the day, what excites me the most when we've talked throughout this whole thread of podcast series is that we know educators want to know more about mental health issues, that they want to know more about things like early psychosis and those early findings that Dr. Calkins talks about. supports what I've known from work in schools and with people in schools is that people are willing to share with us and be vulnerable with us so that we can better create training, so that we can better collaborate in ways that will be helpful to the children and adolescents that we serve, that will be helpful to the families that we serve, that will be helpful to all of our colleagues in K-12. So I think, great work is starting in this area, or is picking up in this area, because there's already so much great work going on at places like Children's Hospital of Philadelphia with Dr. Moxham, and all of the work that Dr. Calkins leads and heads up. So when you ask the question about how can we collaborate better together, the survey that we're doing is definitely one of those collaborations. And I know the three of us are so thankful that so many school counselors and psychologists at this point have been willing to share their understanding of early psychosis.
But I think that leads into as well, our schools are really making a concentrated effort to provide more services and support for students. You know, coming into more SEW based supports or even SEL based curriculum. So how can our medical community and our medical providers build better partnerships with school, particularly when we consider HIPAA and FERPA? And these things sometimes create walls instead of bridges, so that we're really making an effort to support the whole child.
So if I can just share Dr. Calkins and Dr. Moxham, the way that I met the two of them was actually at a conference where I was asked to explain a little bit more about how K-12 systems work to clinicians. It's exactly how I met the two of them. The medical community in that case was saying, look, come explain to us a little bit more about K-12, how K-12 systems work, so that we can better collaborate together. And then at the same time, the other work I'm doing behind the scenes is advocating on behalf of the medical community in K-12 situations of, hey, look, this is how the medical community works. So when people like Dr. Moxham and Dr. Calkins come forward and say, hey, look, we want to collaborate together, our systems don't necessarily square up exactly because of those issues, like you said, Shannon, like HIPAA on the medical side and then FERPA on the education side. But when people start talking to each other and people are willing to sit down and hear each other's perspectives, and even what might be barriers to collaboration, in my mind, that's really a great way to build bridges across systems that we need. Because what I do know is, as an educator in K-12, I don't I don't know, I can't diagnose, and I don't know what treatment to provide. But what I can do is look to people like Dr. Calkins and Dr. Moxham and say, here are your areas of expertise. How can that translate into a K-12 situation? So whatever treatment you're saying would be best for children that we can do practically and pragmatically on our side can play out. So that's my side of thing, and how I met Dr. Calkins and Dr. Moxham, which was really like a, hey, let's collaborate together on this because we want to build bridges. So I'll be interested to hear what Dr. Calkins and Dr. Moxham say from their side on the medical and research side.
Yeah, I think since I'm a child and adolescent psychiatrist, and most of my patients are in that age range and in K through 12, I've honestly found it harder to collaborate with schools than I anticipated it being, in terms of just very concrete things like availability, in terms of our schedules aligning for times to talk, to times to coordinate, IEP and 504 meetings happening, ability for clinical team to join those sort of conversations. There's just a lot of difficulty in terms of arranging so many professional schedules, especially not being co-located and having different responsibilities to the identified patient. I can think of like some kind of like grand scale ways of pathways to care in terms of organizing payers, in terms of insurance providers, conduits from schools into clinical settings. But I think it's really difficult, especially in the city where we practice in Philadelphia, where there are so many schools, a bunch of high need schools, a lot of charter schools, with different expectations. I think that's a real barrier in terms of early identification and early referral, is kind of gap between the school setting and the clinical setting.
Yeah, I would just add to that is an important gap. And also what you were saying, Dr. Moxon, about the kind of communication with with schools. I think one of the things our survey also found was that the minority of school professionals reported that they would advocate for a student experiencing psychosis to attend class in a typical school setting. And that's an important finding, because one of the things that our early intervention programs do, and we have one also at Penn for ages 16 and up, it's the Penn Perk program, and there's actually 17 first episode programs across Pennsylvania. But one of the things that our early intervention programs do is really encourage and work together with the individual, not just on medication management or individual therapy, but in this coordinated specialty care model, we're also doing supported employment and education support in order to really bring the person back, under that recovery model, back into their typical environment for their developmental stage. So having this disconnect where we want people to go back to school, to be in school, and having hurdles and obstacles to getting the person back into school, I think is a big challenge, and something that could also really be important for young people who are experiencing psychosis.
On the education side of things, there is a huge focus right now on student-centered learning, encouraging our students to build voice and agency to become advocates for themselves. So how can we best help students and staff feel safe naming what they see, feel, or suspect without shame or fear of backlash?
I think that's a big part about how you approach these symptoms. I might keep coming back to this because I think this is the conversation I have over and over again with other clinicians and pediatric providers, is that having psychotic-like experiences or psychosis symptoms does not mean you have schizophrenia, and does not mean you have a psychotic disorder. It really can be part of the full spectrum of human experiences, from normative to pathological. So I think approaching these symptoms or experiences with curiosity and trying to understand them and contextualize them is a kind of way that people from the school can approach it in a non-stigmatizing, more open way.
Yeah, I would agree with that, especially going back to what I mentioned about stigma and the messaging that we get from the media. That association with violence that you see with psychosis and schizophrenia is so pervasive in our movies and our TV shows, and just every form of media, video games, social media, that it's become something that's ingrained in our culture for people to hear about someone's hearing voices or having odd beliefs or being suspicious, of other people, and to have this knee-jerk fear associated with it because of the association that has been shown so many times in the media. And so that becomes internalized for the individual who experiences these things. They worry about, what does this mean about me? Does this mean does this mean I'm quote unquote crazy? Does this mean that I'm going to kill people? And it, of course, it affects all professionals. We've seen studies that have been done in even medical providers, and in a lot of people hold these beliefs, and in part because they're so readily available in our culture, unfortunately. So just recognizing, I think, knowing that first of all, that association is largely false, and also knowing that is a stereotype that leads to fear and anxiety can go a long way.
Dr. Moxham, I wanted to circle back around to something you just said. When I hear a statement like you made, that we should be approaching perhaps symptoms or experiences that a child or adolescent is having with curiosity and open-mindedness to understand a little bit more. As an educator, that makes me so happy to hear that, because we talk about that very approach to so many things within education. So then to hear a child and adolescent psychiatrist talk about using that same approach that we use within school systems around what might be a symptom of early psychosis is really very helpful to us. So My question to you really is then, can you tell us a couple of symptoms that might show up in children and adolescents that could be an indicator of early psychosis that we should explore with a little bit more curiosity and open-mindedness?
Yeah, I just want to say maybe that's a universal truth about working with children is coming at them with curiosity and openness.
I
'Cause,
agree. I love that.
yeah, they really know when someone's not being sincere, and that kind of just shuts them down. So the same is true for my work as I'm sure it is for teachers. I used to be a teacher, so I think that is a helpful aspect of this. So specific symptoms, I think things that are maybe more alarming is when you see symptoms starting to interfere with someone's typical flow through their day or typical behavior. So a lot of people or a lot of teenagers, like Monica said, 7-8% are have experiences hearing voices or strongly held beliefs. So maybe there'll be multiple kids who are hearing voices. Maybe there'll only be one or a few kids who are talking back to the voices. So once they're starting to become distracted, whispering to themselves, seeming to have more the psychotic symptoms of it, take on more salience, more meaning to them, that is usually easier to identify in terms of not probing too much because it's an observable behavior. And it also puts them more at a threshold of this could be concerning.
That's such a great example to me when I think about having been in an elementary school setting for a very long time. I can, something that comes to mind is it's very typical development for children to have imaginary friends. And there are times when I would be working with families and they would be worried about, is this typical? Is this something I should be worried about, that my child in second grade has an imaginary friend that they talk to? And there is that context then of exactly what you're addressing right now is figuring that all out. Those are the kinds of things that come to mind, that we don't want educators, when they hear about children hearing voices talking back to them, to necessarily rush to judgment, because there is some level of typical development. But then having folks like you help remind us of probing a little bit further into that, whether it's, trained professionals within a school or referring to you or to people that Dr. Calkins leads in the Heads Up Clinic.
Yeah, I think it's a really good point. Because I do get a lot of referrals for like 6 to 10-year-olds who are reportedly hearing voices or have imaginary friends. And that is a lot of the conversation of like, there is a normative process here too, where imaginative play, imaginative thoughts, magical thinking is normal. And it's a common, healthy way, can be a healthy way for children to deal with distressing thoughts, distressing feelings.
And just to follow up on that, I think the point that you made, Dr. Moxham, that is super important here is the behavioral change for that individual. So in a decline in school or work, or withdrawing more, maybe appearance or hygiene, the person looks odd, or maybe they seem a little confused or puzzled, or is talking in an unusual way. Those would be additional signs. This isn't just typical development, in my view.
So what does a true early intervention ecosystem look like in a K-12 setting? And what would need to change to make that happen at scale?
Dr. Calkins and Dr. Moxham, if you could wave a magic wand, how would you answer that question? Because this is where I think educators need to stand back and listen to what you all have to share about what we really can be doing to provide a supportive environment. So wave your magic wand. What can we do different in K-12?
Well, I mean, if we had unlimited funding for mental health supports in schools, that would be great. But I think that's probably unlikely. So I think we've been kind of zooming in on two points. One is the identification and screening and identification. And then the other is kind of working with the schools, mental health professionals, working with schools after a young person has been identified, and kind of helping to support them continue on in their schooling. So those are two like not unrelated things. And I think, we should be screening for psychosis, just like we do for depression or anxiety or substance use or anything else. If a child is getting a mental health screener, we can't be afraid. I think it's, we can't be afraid to ask about psychosis as well. So that's one point. And then, yeah, working with on the back end, recognizing that young people with psychosis, even if they have already experienced a first episode of psychosis, can and should return to school if possible.
Yeah, I would just say like dreaming big too. There are standard treatments for someone who has early psychosis. There's a gold standard treatment called coordinated specialty care, which Monica's clinic PERC and CHOP's clinic tries to implement. And it's a multidisciplinary team following these kids and families over the course of 2 to 4 years, depending on how many years of step down they have. And the team is comprised of psychiatrists, therapists, peer support, support education, employment support. But there, ideally too, when kids are in school, there would also be a representative, someone who has their boots on the ground at the school as part of the treatment team. Because ideally, the kid spends up to 8 hours a day at the school, and that's usually their primary social outlet. So we'd want someone there too who's heavily involved in treatment, making sure things are being guided in a more proactive way.
We all know that funding is always an issue in our schools, whether we're looking at mental health resources, getting the supplies and resources that we need for the students. So if you had to prioritize one shift school should make tomorrow to better support students at risk for early psychosis, what would it be and why?
I talk about the screening. I'm just going to go back to that again, because I think that is a relatively low burden approach to really potentially big things happening for a child. So if someone just notices that this person may be experiencing early psychosis and follow steps to, you don't necessarily have to do anything further to the evaluation. We have at Heads Up, we have what's called the Early Psychosis Mentor, which is a free consultation service where any person working with a young person in the state of Pennsylvania who has concerns that maybe this person has psychosis, they can write to us and consult with us, and we can help them figure out next steps. So that would be what I would say is just having that awareness and knowledge, and to kind of just put this on the radar. And then, it doesn't necessarily mean that all the other things, that you have to do a lot after that, but just kind of notice this kid, I guess.
Yeah, I think like noticing is huge, and then trying to support the adaptive behaviors that we know decrease the chance for development of psychosis. So in terms of like staying engaged. So if they're working with their counselor and they used to play a sport, trying to encourage them to continue to play that sport, try out again for the next year, join clubs. Is there any sort of like academic slip that could be addressed? And then in terms of addressing the risk factors, harder for schools to do, but I would say the biggest risk factor to try to address is substance use. But I honestly don't know how the school did. I'm not sure if anyone has found a way to get teens to stop smoking weed, honestly. But that would be my wish, is that the schools could figure out a way to make it less likely to occur.
Yeah, and that's so that adaptive mode that you're talking about. I think with psychosis, another one of those stereotypes is that people who have schizophrenia or psychosis, like they can't, they're not going to be able to do the things they want to do in life. They're, going to become a burden for themselves and for others. And, that all of that is actually counter to the therapeutic approach that we take, which is to get people back doing the things that are meaningful to them, because that can really help the person develop a sense of autonomy and self-sufficiency, and can kind of counterbalance and even distract from, if the person is continuing to have some psychosis symptoms. So many times people are surprised to hear that, like, oh, is this too much for the person? Is this going to be too stressful? But actually, we do it staged. You don't just jump right into X, Y, or Z, to back to varsity sports or whatever. But the goal is often, if that is the individual's goal, to get back to doing the things they ordinarily would be doing. And then cannabis, yeah, I mean, that's a whole can of worms. We know that there's a direct association between the use of cannabis, the quantity, the amount of cannabis people smoke or use, the timing of it. So the earlier the onset, the more likely it is that the person is going to develop psychosis. And the thing is that we don't know, any kid, who smokes cannabis actually is elevating their risk of developing psychosis. We just don't know which kids those are. And so, in the gold standard would be nobody under the age of 25 should be smoking weed. Well, we know that's not realistic. So but it is super important for everyone who's in contact with kids to know that there is an elevated risk of psychosis associated with the use of cannabis.
If we could go back to the systems just a little bit, how do systemic inequalities like underfunded schools, racial bias in discipline, lack of access to mental health care compound the risk for marginalized students being misidentified or overlooked altogether?
Yeah, so I'll focus on the race component of that because there's been some really important work that's been done in a meta-analysis that's kind of a systematic review actually of studies that had looked at pathways to care for young people who had experienced psychosis, who were Black individuals with early psychosis. One of the important things was that as young people were growing up and sort of beginning to show some of those early signs of psychosis, there was an increased likelihood that those signs would be misattributed. So to other things like depression or substance use or to typical adolescent development. And that was more so for Black youth than for other youth. And that's a very compelling finding, in part because we know that, especially for Black youth, where those signs and symptoms are missed, that can really increase the likelihood that the person's going to have a longer period of time before they come to care, and that the kind of care that they end up entering into the mental health system can come about in a very emergent or kind of problematic way, such as involvement with law enforcement or involuntary hospitalizations. So that's something that is especially true for Black youth. There's other cultural factors across many different cultures where especially psychosis symptoms are, highly stigmatized. That's true, just more generally, but especially in some cultures, there's a high rate of kind of shame and fear associated with psychosis symptoms, which can also play a role. It just touched on something that I just wanted to emphasize because we haven't talked about it so far. And that is that for anyone, one of the things that we found is that the longer people experience psychosis symptoms without getting treatment, and that's what we call the duration of untreated psychosis, the longer that goes, the poorer the person's outcome is likely to be in the long run. And there's many, many studies that have shown that ideally, if someone has the onset of psychosis symptoms, that the ideal gold standard would be they get to care within 3 months. In the United States, it's about 12 months, and that's true in Pennsylvania as well. Some programs have gotten that a little bit shorter. So what that means is that people can be experiencing psychosis symptoms for a long, long time before they get to care, which ultimately can decrease their chances of a good recovery and outcome. I mean, that's true generally, not just for people from marginalized backgrounds, but it would be particularly compounded for people who are more likely to be overlooked or misidentified, including Black youth.
Then what happens when schools do flag concerns, but there's no follow-up? There's no counselor capacity or no clear protocol?
That's a great question, Shannon. And this is where I look to Dr. Calkins. She earlier referred to being able to reach out to trained clinicians and other help and heads up. So I actually will pass the baton over to you, Dr. Calkins, and give you a little bit more space to talk about when, in the state of Pennsylvania, school counselors are still not mandated. It doesn't happen often, but maybe in smaller systems, there's only a counselor, maybe who is on leave, or it's a counselor who moves in and out of the system. And so I would really look to you and say, knowing that there may be constraints within a school system, can you go back and talk a little bit more in depth about what can administrators, what can any educator who's working with a child they're concerned about do to reach out to all of you, and what help can you provide to schools in case there isn't someone there trained to do it?
Yeah, so generally, I mean, it's definitely a problem, that if there's low capacity and no clear protocol. I think with our Heads Up Early Psychosis mentor, what we typically would do is if someone poses a question to us and says, I have a kid who's showing these symptoms, and that can be anyone, it could be a teacher, doesn't have to be a counselor. So it's just, again, somebody noticing. We would then work to help to provide resources within that area. Ideally, there might be a program, one of our programs, but our programs, as much as, we have 17, but they still don't cover the entire state, and they don't necessarily cover the clinical high risk symptoms. So then it would be a matter of our team doing some investigation where we can help to identify local resources around where that child is located, and then work with the referring individual to provide that information. And, if with permissions, if there's permissions in place, we can also, make direct contact with the family. So that's to be able to help them get connected to available resources within their community. But that's kind of, it's done on a case by case. There's no one, everything's very unique in terms of the individual situation, their age, their location, their insurance, all of that, definitely plays a role in terms of what follow-up steps might happen next. But again, the identification, is this a worry? And we can say yes or no, this sounds to be, it may not be, or it's likely to be, So Dr. Moxon, would you add anything to that?
The only thing to add is that I imagine it's hard for the school counselors and school psychologists and nurses to keep in their minds all the subspecialists that they should refer to for various things. The Heads Up resource is an amazing resource and should absolutely be utilized. And I also think it's in the wheelhouse of a lot of pediatricians, like primary care pediatricians, to do a quick mental health survey with their patients, in terms of just identifying or kind of cataloging symptoms and distress and need for referral. So I would also say schools can kind of work with the families to make sure that they follow up with their pediatricians, especially if the schools are under-resourced. They don't have the time to do deep dives into these things. Primary care providers can be a great pathway to care because so few children have therapists or psychiatrists. Almost every child has a pediatrician, and pediatricians often have access to tips, so telephonic psychiatric interventions where they can call psychiatrists on call to get information. But I think that would be the other kind of route that the school could take in terms of referral.
Now, if we could touch base on policy for just a minute, whether we're looking at a district or state level policy, can you think of any that you feel need to be rewritten to better support proactive intervention rather than reactive punishment?
Well, when I think about really where district policies typically come from, they're driven by mandates at the state level. And so when I look to mandates that help us have a greater understanding of mental health kinds of issues like anxiety, like depression, like suicide, I look to mandates like that and say, can we expand that mandate so that we look beyond just high incident kinds of mental health struggles and disabilities that children have and move more into a space and build in that space to areas like early psychosis. And always when I look at mandates, one thing that I hope for is that they aren't unfunded mandates. Right now, Pennsylvania Commission on Crime and Delinquency has done a wonderful job of helping to get training that falls under Act 55 requirements of two hours annually of training in topics like behavioral health awareness, like suicide and bullying awareness. They've done this wonderful job of utilizing funding that's been set aside to make sure that training gets to people. So I don't know if it's so much what rewriting of what's there, but how do we take the mandates that are already there? How do we take then how that trickles down into schools in their policies and practices and protocols and build on the foundations that have already been established by things like Act 55, like Act 71 around suicide awareness, prevention, intervention, and postvention, Act 18 that helps us better understand behavioral threat assessment. I think it's really building the framework in all of those systems. And to, Dr. Calkins' earlier point, we hope that funding doesn't decrease or lapse altogether, but that it actually increases so that we have a better understanding of this. I will always place my hope in a good quality training, in having partners like Dr. Calkins and Dr. who can help us in schools better in this space. So it's a little bit of let's keep working and moving in the direction we are in the Commonwealth, which is really at the forefront of many states in the whole United States. And let's keep working on the training and increasing our literacy so that we engage in best practices. And then also let's make sure that we ask our lawmakers to keep providing funding for that training and for resources.
In your current research, what have you found in regards to adolescent brain development, trauma, and early signs of psychosis? And how can that science better inform school practices?
So I think generally speaking, so we know that psychosis and schizophrenia are what we call neurodevelopmental disorders, where there are multiple factors, biobehavioral factors that are kind of predisposing a person to the risk of psychosis. So that includes genetic risk, various biobehavioral risk factors, and then as a young person's developing, social adversities and traumatic stressors can kind of interact with that pre-existing vulnerability. We mentioned cannabis use earlier is another effect another contributor. And so one of the things that we're working on right now is the Accelerated Medicines Partnership Schizophrenia, which is a large scale international collaboration of more than 40 sites across the world who have identified 2,000 young people who appear to be at clinical high risk of psychosis. And we're following people over time for at least 2 years, hopefully longer. We get the funding to extend that follow-up. Where we've done a comprehensive array of biological markers, including imaging and blood work and all kinds of biobehavioral measures, and looked at things like social adversity and traumatic stress exposure, substance use, to look at different trajectories that people may have where we know that some of those young people are not going to develop psychosis. Some are going to kind of stay about the same with these clinical high risk symptoms, but not really getting worse or better. And then some people will go on to develop a psychosis. So this is a landmark study that we're hoping will be able to better answer your question, that will help us to really understand what the various signatures develop neurodevelopmentally there are to different pathways that and outcomes that may occur in young people who are at risk.
Yeah, I would say maybe the largest thing schools can do in terms of decreasing chance is keeping kids engaged. Because like Monica was saying, we know that trauma is a risk factor, and trauma is hard to avoid, especially in certain communities. So the more someone stays engaged in school and sports and clubs, it usually keeps them more connected to a community and more connected to adaptive behaviors. So that would probably be like the most concrete way that schools could decrease the chance of progression of illness. It was kind of just by keeping someone engaged in adaptive behaviors.
Based on your research, do we have a crisis addiction in education? And are we only mobilizing when a threat is imminent but fail to sustain long-term preventative work?
Shannon, I'm so glad we're ending this podcast with this question. This is where, to me, I actually have the greatest amount of hope when I think about just the word crisis and its root, a Greek Greek, it's rooted in Greek, in the word crisis, and meaning, crisis is a turning point or a time for us to make decision or judgment where things can either improve or they can worsen. And I feel like when I look at podcasts like this, and I have an opportunity to have people like Dr. Calkins and Dr. Moxham start helping us in schools with, addressing issues like early psychosis, then I see, while there might be a crisis of like the only time or many times we seem to respond to things in schools is very reactively, I see opportunities like this in that crisis to learn more, increase our mental health literacy, and understand that we don't have to be reactive in a crisis that might pop up where we're concerned about a child and behaviors that they're displaying that are concerning to us, but that there's actually help. There's help from people like Dr. Calkins and all of the wonderful work that she leads in Heads Up. There's hope in all of this for children and families, and that knowing that educators are better equipped to deal with this. So while there might be some of that crisis, I really just look at the word and think about the possibilities of doing better in school. Knowing better and now doing better really comes out of collaborations like this, out of the study that we're doing to understand what people in schools know about early psychosis. So that's where I'll end up, but I certainly want to hear from my colleagues too, what they see moving forward in schools as far as working in collaborations like this.
Yeah, I think partnerships are the future. Like I said, there's 17 psychosis programs, first episode psychosis programs across the state. And I think a bit of it is the onus of those programs to do outreach, which is something every program does, to connect with the schools in their area. And like having run the CHOPS program for the past few years, we have identified certain schools that for whatever reason there's a higher instance of referrals from those schools. So now we are in regular email contact with those counselors. We also have the schools that we typically refer to if someone's been out of school for a while and needs to transition back into a school. So these clinics are making relationships with schools, and I think those relationships will strengthen over time and just make referral pathways that much clearer.
I can't thank the three of you enough for sitting in and having this conversation with me today. This has been truly eye-opening as somebody that has over 20 years in education, but I'm not a mental health expert. Just the lens that you have provided today, I think is just it's powerful and it's so very valuable to our educators across the state. So as we close out today's episode, one message stands out loud and clear. We can't keep waiting for a crisis to care. Understanding early psychosis isn't about jumping to labels or creating fear. It's about building systems of awareness, trust, and timely support that help students before they slip through the cracks. From recognizing overlooked warning signs to rethinking how we define at risk. This conversation reminds us that our words, our systems, and our silence all have power, for better or for worse. We've discussed the dangers of over-pathologizing, the impact of stigma, and the urgent need for real partnerships between schools and providers. But perhaps the biggest takeaway is this: early intervention doesn't start with a diagnosis. It starts with curiosity, compassion, and the courage to look deeper. So whether you're an educator, a counselor, policymaker, or parent, ask the tough questions, challenge the assumptions, and push for the policies that make early support possible, not just reactive responses when it's too late. Thank you for tuning in to Lesson Learned, the official podcast of the Curriculum, Instruction, and Assessment Department in Midwestern Intermediate Unit 4. Until next time, continue to educate, innovate, and inspire. We'll see you soon.